Okay, so my name is Susan Anderson. Today we're going to be talking about, excuse me, well, excuse me. I'm just going to start there. Okay, good morning, everybody. My name is Susan Anderson. I have a bit of a cough today. We're going to be talking today about some tips for transcribing surgical reports. I have talked with many students who seem to really struggle with this work type. Surgical notes are often very difficult for students for a multitude of reasons. So there are many different types of surgeries and procedures. Some are scheduled, some are emergent, some are cosmetic, and some are elective procedures that are necessary procedures. So, excuse me, surgeries can be very short and minor, or they can be very long, tedious, and involved. They can be on any part of the body, and this adds another degree of difficulty. Then there is all the medical terminology involved. There are all the directional planes, not to mention all the different types of tools and devices. I mean, how many types of clamps can there be? Why so many with different names? The list goes on and on. Each tool has its purpose, though, and each has a specific name. Then there is, excuse me, the degree of difficulty of the dictator. So, is this, does the dictator have an accent? Is there background noise? How many times has he or she dictated this particular report, this procedure? If it's a common one, then it's probably going to be dictated at a rapid rate, and this makes understanding a new report type even that much more challenging. You would think and, well, hope that dictators would slow down for these really difficult terms, but oh no, you know that's not the case. This is where they seem to fly for some reason. It is very frustrating. I've been there, done that, for sure. Repetition really does help with this work type. The more you do, the more familiar you will become with these phrases, terms, tools, sutures, etc. The point I want to make with you guys today is the more, excuse me, I apologize. It's so important to know your anatomy. Where is everything located? Well, I mean, you want it to be a little bit more involved than this, okay? You want to really know the terms and everything. But it's just critical, and it's another reason that it's so hard to transcribe transcribe surgical reports is that you never know what type of surgical report you're going to get next. One report could be on a foot, the next could be on a heart, and the next report could be a hemorrhoid surgery. You get the picture. Anyway, because a surgery or procedure can be done on just about every body part, it just adds another degree of difficulty. And without being exposed repeatedly to that particular surgery, it's difficult to learn that particular surgical term, those particular surgical terms, tools, and everything that goes along with that report. It's just hard to become familiar with surgeries until you start doing them on a consistent basis also. If those aren't the work types that you get on a consistent basis, it's just hard to get them. If you get them sporadically, it's just more difficult. The phrases are different. The medications are different. I apologize, you guys. The terms are different. There are, again, so many new tools and devices that take time to research. You have to find good websites. The most important thing to remember, again, is that it's critical that you learn your anatomy. For instance, there are terms that sound very much alike, but are in different parts of the body. Don't ask me why whoever named medical terms to begin with could not have come up with terms that did not sound alike. Like, for example, these three terms, peritoneum, perineum, perineum, and their adjective forms, peritoneal, perineal, perineal. Well, as you can see, they sound alike, but they all three have very different meanings. I mean, seriously, could they not have come up with different names? But you do need to familiarize yourself with these terms because you will come across these. And you know that dictators do not always pronounce them clearly. I'm sure that you all know by now what I mean. The fact that dictators do not enunciate clearly is not a shock to any of you. So today we're going to talk about surgical reports in general. We're going to talk about the elements common to most surgical reports. We are going to talk about a few common operations with common terms, phrases, medications, and tools. Everybody has lost sound. We'll just take a quick break here. Okay, just keep trying you guys to get in and out. I don't know what else to do. I'm going to keep going. This will be on the webinar, on the forum if you can't hear. So I can't stop and start. So anyway, I'm going to keep going because I'm kind of timed on this. So, so we're going to talk about the elements common to most surgical reports. We're going to talk about a few common operations with common terms, phrases, medications, and the tools that are frequently used with those procedures. So let's get started. What do most surgical reports have in common? Well, the reports will all tell you what took place during the procedure, who was there, what medications were given, etc. Some of these will be listed as headings. So let's look at some common headings. Okay, so most reports should have some form of pre-op diagnosis and post-op diagnosis. But you know there's always that one doctor out there that won't put it on there. So it's not going to be on every single one of them. But you do need to remember to change to ES if there's more than one diagnosis, if there's one item listed under there. Many times dictators will start a list, but then there's only one item. So you need to be responsible for going back and removing that number one. Doctors will do this often. They just forget about it. They'll start off number one and then they'll forget. And so you need to be the one to go back and remove that number one. If same is dictated, be sure and transcribe exactly what is dictated and transcribe from the preoperative diagnosis. Do not write same. Note that the post-op diagnosis can be different than the pre-op diagnosis. The pathology that's found in the diagnosis once the patient is opened up on the table can change the diagnosis. So going into the surgery, there may be one diagnosis, but the outcome of the surgery may bring about a different diagnosis. The pathology may prove cancerous, but it also could prove the opposite. So on this diagnosis, it's suspected diverticulitis, but the outcome is a normal colonoscopy. So many times surgeries will rule out a suspected diagnosis, and that's good news for this patient, right? So here's some common headings that you will hear, but not all of these will be on every single report, of course, but do dictate these if they're, do transcribe these if they're dictated. Now, if at the beginning of the report the dictator says type of report, there's no need to transcribe that. That's just information they're giving you, the transcriptionist. If a dictator says type of report, cesarean section, well, you do want to transcribe that. Date of dictation, yes. Sometimes dictators will dictate later, sometimes much later. Sometimes they forget to dictate a report. And then sometimes they lose a report or somebody messes up and they have to redictate. And so the date of dictation is important, and you do need to transcribe that. Location, of course, we scrub that information here as per our account specifics. Be sure to add that in too. Now, let's just quickly remember that I'm giving you these as headings, but it could just as easily be written in sentence format. So, again, per our account specifics, no verb, make a heading. Chief complaint, severe headache, no verb. There's a verb, is, in the next one. Chief complaint is severe headache. So that is a sentence, and you do not make a heading. Of course, the exception to that is the assessment, diagnosis, impression, where you would make a heading for that. And that's in your account specifics. Here's some more common headings. Why are the counts important to note? Well, leaving a sponge needle or instrument an instrument inside of a patient has been done on more than one occasion. This has led to infection and death even, and lawsuits. You better believe it. So from after that, counts are done, and you will hear sponge, needle, and instrument counts were done ×2. I've heard even ×3. They will not close a patient up until that count is correct. Now, sometimes you'll hear that they will label specimens A, specimens B. That will be noted also. Hardware and implants, this will be noted also. It's important to note that they'll have the hardware, the serial number, lot number. This is a good example right here of a plate in somebody's arm and a wrist right there. And that is identifying information, and it will probably have the serial number on your surgical report. So all of that is important information. Now, one thing to note is that it is okay to start a number, a sentence here. It's not really a sentence, but with a number. And it's only okay in this circumstance where you have short little information and it's under a heading. And that is the Book of Style reference. And it talks about subheadings, but it fits this situation also. So again, I'm showing you these headings, and this information could all just as easily be given in sentence format. Indications for procedure include, findings show, but no verb, make a heading, drop down, put it right under the heading as per our account specifics. And again, these, one thing I do want to note, indications here, plural, reasons, plural, findings, plural, complications, plural, but transcribed verbatim. If indication for procedure was dictated, leave it as singular. It's okay to change to make things grammatically correct if it's like more than one problem and the dictator says problem. You can change it to problems to make it grammatically correct. That's okay. Tourniquet time, why is that important to know? Well, you need to know how long a limb was without blood when they did that surgery. You know, in order to do surgery, you need a bloodless field. And so you have to put that tourniquet on to drain the blood in order to get that bloodless field so that they can have visualization. And so it's always going to be given in millimeters of mercury, and that is how it's formatted, that mmHg, and you will see that very often, especially on, you know, your limbs, your feet, your hands, your like that, arms. Excuse me. Condition. These are a few more. Condition. Sometimes it's just written in paragraph format. The patient was sent to the recovery room in satisfactory condition. But this is also important to note for legal reasons. They need to know how that patient was doing. Remember, don't make a heading if one is not dictated unless you're in the assessment, diagnosis, and impression sections. Disposition, where did that patient go? That's important information. Went to the recovery room, or maybe they were sent to the ICU, maybe there were complications or something like that. Very important to note. Now let's talk about expanders for just a bit. I use expanders for everything, and I don't know if everybody is using a word expander yet, but you will at some point, more than likely. Not everybody is all on board with expanders, but when it comes time in the course for you to start using expanders, it's after your Pi 1, I would suggest playing around with it and starting to make some. If I type out the letters HPI, it automatically, now I have to make mine, make entries for mine because I use shorthand. Some word expanders come with prefabbed entries, but I make mine, and so I make mine expand. I put it in as lowercase, and I make it expand to all caps. Easy breezy. If I want to expand it out to history of present illness, I make F my letter. Expands everything for me. Like I put that on the end of everything, and it expands everything for me. So if I put HPIF, it expands to history of present illness, lowercase. If I put H on the end of HPI, it expands. That makes it a heading for me. So I can make anything into a heading, just with that little H on the end. I have to, of course, make an entry for it, and I have to format it in that way, but it's all easy once you know what you're doing. Now, we don't use bold here, but some companies do. And B is my letter for where, it bolds things. So I can put HPIB, and it bolds it. And, of course, you have to format that in my shorthand. It just takes a second. And you can see I expand it with my H and then add the B, and it's so easy. Once you start doing this, you guys, you can underline, you can put a colon on the end, you can have it drop down below. I mean, the possibilities are just endless. And time is money. I'm just telling you, y'all, if you would work on these word expanders a little bit at a time, and make some of these common headings, you would not be typing out all these headings. Think about how many times you're going to write out history of present illness over your career. I mean, it is worth the time and effort to put in an entry. Saves you a lot of time and entry. This is, just a couple more here I'll just show you. Sponge and needle counts. Now, the thing about these common phrases is that you have to be verbatim, because they're said in so many different varieties. Okay, so right here, sponge and needle counts, sponge and needle counts, sponge and needle count or counts. And then sponge, needle, and instrument count, and then times 2, and then there's just some other ones that I use here. You have to be verbatim. I take the first letter of each word and just add it. It just makes sense to me. And you have to come up with your own system if you add your own entries. But again, you quickly make your own system and make it work for you. And it's worth the time. This is another thing that I do consistently all the time. I put in a base word like instruct, and I make like the keyword is INS. And then I put S for my plural, D for past tense, N for TION or ION, and G for ING. Using that same principle, T, present, S, presents, D, presented, G, presenting, and N, presentation. So it's worth the time and effort. I just would say that. You use these same phrases, words over and over again. So just touching on that. So let's go over some common surgical phrases. You'll hear these very often. Some are for legal reasons. Sometimes dictators just fly through these, though, and they're very difficult to understand because they say them so often. You'll hear some form of these sentences. Risk, benefits, alternatives, and possible complications were discussed in detail. They could say that 1,000 different ways almost. Risk, benefits, and alternatives were discussed with the patient. Risk, benefits, and complications were discussed. Informed consent was obtained. The patient was taken to the operative room, operative theater. The patient was identified in the holding area. A timeout was taken. Now, a timeout was taken is important because different patients have been incorrectly taken to the operating room and had incorrect surgeries done on them. So that's very important that a timeout was taken and they identify the patient and they make sure they have the right one. Use your word expanders. Make sure you're spelling everything correctly. Be verbatim. Make sure that, when you expand your, use your expansions, that it is exactly what the dictator is saying. My rule for adding is if I use a phrase twice, I add it. It's worth it. A couple more you'll hear over and over again. Left the operating room in stable condition, no complications, blood loss was minimal, hemostasis was achieved with Bovie electrocautery. I mean, if you just think about how many times you will write that over your career and how long it would take you to make an entry, I mean, it's just so worth it. Sponge, lap, and instrument counts were correct ×2. One thing I do want you to note on this one is that many times doctors will say counts was or count were or something like that because they're multiple. Just make it grammatically correct. If they say counts, make sure that the verb is were. If they say count, make sure it's was. It's proper either way, but the verb needs to match the subject. Again, that's very important to note, okay? Okay, let's talk about anesthesia just a bit. I'm going to briefly talk about the different types of anesthesia. Your course has some great information on this, and I'm going to link some websites also. So your local anesthesia is basically, it's just going to numb you, the part that needs numbing. It's minor anesthesia, minor procedure. Regional blocks a whole area, and it can be spinal, it can be for planned procedures or pretty much planned procedures. Labor delivery, your orthopedic surgeries. Nerve block is for like pain relief, and surgeries after you're done. So monitored anesthesia care, this is something that they call it maybe twilight anesthesia, where they can still talk to you. You're kind of aware of what's going on, but the anesthesiologist can give you more if you're in pain, or they can bring you out of it quickly. If they find, like, for example, if they did a colonoscopy and they found a polyp, they could put you out. This is what that's called. It's monitored care. General anesthesia, they're going to knock you out, basically. And this could be done breathing mask or IV. And again, the anesthesiologist will be right there monitoring your vital signs. And here is just some more information about anesthesia. And again, your course has some great information about it also. Let's talk about surgical positions just a bit. Surgical positions, procedures are done in certain positions for ease of access, being careful not to put pressure points on nerves and or do any damage to patients. So patients are in these positions for sometimes long periods of time. You'll hear this phrase often: pressure points were well padded, and that's to protect nerves from damage. Just think about, like, if you sit in an odd position and your foot going to sleep, and think about that if you were in that position for longer than that, it would probably do some damage. So these are the most common positions. Supine, you're lying on your back. Trendelenburg position, you're supine with your feet higher than your head. And there's a reverse Trendelenburg. You'll hear different, there are other positions that are, not, these are just the most common. Prone, you're lying flat on your stomach for back surgeries. Lithotomy, you're supine with your legs in the stirrup. Lateral, you're lying on the non-operative side. And the school has great information with pictures for these positions. And there's some more information right here. Excuse me. So these positions will make sense to you when you know what body part is being operated on. So let's just talk briefly about tools and instruments. So I'm going to give you some websites, and I'm going to mention briefly that I like catalogs with pictures of the tools. It just helps me make sense of what what is what. You know, everything has a specific name. Everything has a specific purpose. Needle holders, scissors, hemoclips, clips. Right here, this is they have retractors that are holding the body open so that the surgeons can get in there and work. There are hemostats. There's a drain. There's like with suction in there. There are clamps. I mean, who knows what all's in there? I mean, there are clamps. There's hemostats. I see, and then of course, you know, they're just digging around in there and doing everything. They have to have that area to see. And again, if you can stomach it, my best advice is to watch a video, and you really get a sense of what they're doing. They're talking about the tools as they're using them, and it will really help your understanding. Again, some people don't want to stomach it, and I get it. I get it completely. So basically, there are 4 types of your instruments: cutting and dissecting. These, just what it sounds like, cutting through skin, tissue, and suture material and other assorted materials. Clamping and occluding, these are used to close off or compress blood flow. Retracting and exposing, these are just used to help this surgeon gain visualization to the operative field. These instruments retract organs, tissues, spread ribs, etc. Grasping and holding, well, basically they do this, just what they say. They grasp and hold blood vessels or tissue. That's some good information right there about the basic types. And this, I'm not a big fan of Wiki. You know, it's not always accurate and everything, but this is a really good site, and it shows you some good pictures, and I think this is worth the look at. Here's some other information about some good sites with pictures, and I couldn't pull up everything. There's some copyright issues, but really and truly, I would just go through them. You know, again, look at all these websites with care, but these are pretty good ones right here. Okay, so let's go through a few surgeries and discuss some common anatomical terms, phrases, and tools that you'll hear on these surgeries that are pretty common to these surgeries. Again, use your word expander after you verify spelling. I just want to stress to you again the importance of knowing your anatomy. It's going to make more sense to you if you have a good understanding of your anatomy. So, excuse me. I'm sorry. So, doing, like for instance, doing a surgery on your toes, that would be metatarsals, but the doctor would say metacarpals, and that happens. So those are in your hands. If you do not have a good understanding, you wouldn't know that. Find good diagrams. Google. Stedman's Medical Dictionary also has some great illustrations. Pull up a picture to get a good understanding before you start your note. It will help you. I'm so sorry. So I'm just going to briefly touch on these, a few surgeries. Okay, so let's talk about cesarean section. This can be emergent or planned. There are lots of planned C-sections now. Some have, because they were prior C-section, prior difficulties. If emergent, they were like failure to progress and they take you right in. That's going to be a general anesthesia where they knock you out. If it's planned, they could probably do epidural surgery. Again, the position's going to be, you know, you're going to be lying down with their feet up, probably, you know, in the stirrups. The incisions can be low transverse, vertical, or low vertical. Usually fan and steel incisions. You're going to hear these terms over and over again in these types of surgeries, and this is just a few of them. Trust me, there are a lot more. But peritoneum, vesicouterine peritoneum, umbilicus, abdominal cavity, lower uterine segment, rectus fascia, placenta, uterine cord, gutters, bladder flap. There's that baby. You'll hear these phrases, but not on every single one. Oops, sorry. There were variable decelerations for that baby. Fascia was incised in the midline. Fascia was extended. Amniotic fluid was obtained. The uterus was exteriorized. Cord was clamped and cut, cleared of all clot and debris. Some more you'll hear. And again, these will not be for every single procedure. These terms will not be in every single procedure, but they'll be in many, many cesarean section reports. Once you realize that there are just so many anatomical parts of our bodies, and so a certain surgery will only contain pretty much those specific body parts, it's going to get easier for you. Learn your anatomy. If you do use a site like MT911, you can search it for anatomical terms, sutures, incisions, tools, etc. using Control+F. These are some more terms, phrases. Control blood was obtained. The infant was handed off to the awaiting pediatrician, and that's awaiting, not waiting. The placenta was intact. That's important to know. No retained products. That's very important to know. You can get infections if there were any retained products left in there. Rectus musculature, Coker clamps, bladder blade, pickups, Metzenbaum scissors, Foley catheter. You'll hear all of these over and over and over again. Just make lists. You know, you're going to hear these over and over again. Again, here we go. Sponge, lap, needle, and instrument counts were correct ×2. The patient was sent to the recovery room in stable condition. And they're going to mention that the location of the baby. The baby was sent to the NICU. The baby was sent to the delivery room in stable condition. And here's some good sites also on cesarean section. So let's look at tonsillectomy. Let's look at another one. So it's usually elective. You could have recurrent bouts of tonsillitis. You could have bilateral hypertrophied cryptic tonsils. Ouch. General anesthesia, they're going to knock you out for that. Marcaine with epinephrine often, but other medications, and they'll give you antibiotics. Uvula, pharynx, fossa, tonsils, oropharynx, adenoids. You can have an adenoidectomy at the same time. Let's see, fossa, soft palate, fossa triangularis. So again, pull-up illustration. Cannot stress the importance of visualizing what you are transcribing about enough. Okay, so I couldn't find a really good one, excuse me, because of the copyright issues, but you guys know what I mean. These are common phrases: bovicularization, indirect mirror visualization, cryptic tonsil, hypertrophy tonsils. No evidence of the active infection. That's good because they don't want to do a surgery on you when you have an active infection. The head of the bed was turned approximately 45 degrees. You'll hear that very often on this surgery. Common tools: Crowe-Davis type mouth gag, red rubber Robinson catheter, MacGyver mouth gag. Again, you're not going to hear the same one. Like, you won't hear a Crowe-Davis and a MacGyver mouth gag. Different surgeons like different tools or different, you know, things. But you'll hear one of these or you know, whatever. But you'll hear these over and over and over again. Excuse me. Apologize. I'm so sorry, you guys. Okay, let's look at another procedure. Phaco emulsification cataract extraction with intraocular lens. I can't talk. It sounds difficult, but you can do it. So this is cataract, basically. This is for cataracts. And it's in your eye. You're going to have monitored anesthesia care. This is just a few of the names of the drugs that you will see. The preservative-free lidocaine or xylocaine, just to name a few. It's going to be preservative-free, though. It's going in your eye. This types of incision, usually some type of stab incision, they'll say. Sounds bad, but that's what it is. Eye, cornea, anterior chamber. Again, can't stress the importance enough of, like, how hard is it to just pull up a picture online, Google, and y'all can pull up a lot more than I can show y'all because of copyright. But you can do a lot more in-depth visualization, illustrations. You know, it just helps you to be able to see what they're talking about. And I'm a visual person myself, and I think it would really, you know, it helps to see, oh, okay, well, there's the anterior chamber, okay, there's the cornea, that's what they're going to do, you know, and it just gives you a good sense of knowing what's going on. Again, he's getting ready to go under the knife there, and here's some more common tools and common terms. Diamond blade, keratome, cystotome, hook, common terms, hydrodissection, balance zone solution. I mean, again, you're going to hear these over and over. And the great thing about the OpNotes is once you learn these terms, you're going to have them in your word expander, and it's going to increase your productivity. And that's what this is all about, increasing your productivity. And most of the people that I know that are seasoned medical transcriptionists, they love surgical notes. Because they've gotten used to them and they're familiar with the terminology, and they have all these phrases and everything in their word expanders. And so it's just like boom, 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 you know. And of course, there's a gross picture of for some of y'all for the eye. Let's talk about the cardiac catheterization. Again, pull up a picture. This is a drawing, so it's not. It says it's not accurate, necessarily accurate, but you guys can pull up a detailed one. It can be diagnostic and or interventional. It's done for chest pain to rule out myocardial infarction a lot of times, and it's done. You'll hear this so often via Seldinger technique. And this is just a few of the terms that you'll hear. Aortic valve regurgitation, stenosis, abdominal aorta, left anterior descending, ventriculography, PTCI, the percutaneous, obtuse marginal branch, atmospheres of pressure, left main. That's not left vein, it's left main. I know it sounds like vein, but it's left main. And left circumflex, and just, you guys will, again, get a picture and just look at it and it'll help you. These are some common tools and phrases. Judkins catheter, you'll hear this over and over. The balloon was advanced. The patient was brought to the catheterization laboratory in the post-absorptive state. I can't talk. Prepped and draped in the usual sterile fashion. You're going to hear that on almost every single report in some form or fashion. Making it word expander. Using the modified Seldinger technique, a 6 French sheath was placed. Pullback method. Intraoperative integralin was given. The left main was a normal caliber, not caliper, but caliber vessel. Okay. Let's say we are going to transcribe a different procedure, one that we had not done before, okay? And it's a bronchoscopy. Okay. What are the steps we're going to do? Well, we're going to listen to the report. We are going to leave blanks where necessary. We're going to pull up detailed pictures of lungs and bronchi. We're going to use all our resources. If very difficult, we'll go to www.mt911 and search for tools and terms. You're going to do your best. You're going to listen to it again, fill in the blanks if possible, make note of the filled-in blanks on your submitted work, and look up these terms to understand them better. Once you get back your submitted work, you know, don't just go over it and go, oh, okay, yeah, that's great. Look up those terms, know what they are, understand so that you get an understanding of what they are for the next report, next time you get them. Listen to the audio and read along with that answer key after submitting the report to build your listening skills so that you'll understand better. And then you move on to the next report. Again, here's that picture. And it shows you the main bronchi. You'll hear the horizontal fissure. These are terms you'll hear in that dictation for that bronchoscopy. And it's going to go down from your epiglottis. You're going to go down, and you're going to hear all these terms. Trachea, you're going to hear all these things. Middle lobe, everything. So you want to listen, pull up a good diagram of that. Oops, sorry. Okay, let's look at another one, a colonoscopy. This is a very common procedure. You guys will be very familiar with this. It can be a screening, follow-up, or diagnostic. Anesthesia is going to be conscious sedation, where they kind of put you out in that twilight state. Usually not an incision. They put you in the left lateral decubitus position. In terms, anus, rectum, sigmoid colon, descending colon, transverse colon, ascending colon, cecum to the terminal ileum. Again, get a picture. See where they're going on that. You hear this all the time. The patient was brought to the endoscopy suite because that's where it's done. Bowel prep was excellent. You really don't want to hear bowel prep was poor, you know. So they don't get a good visualization if that happens. Digital rectal exam was unremarkable. The scope was introduced and advanced to the level of the cecum. The cecum was identified by the ileocecal valve and the appendiceal orifice. You hear this all the time, the same phrases. Make those word expanders. Common tools, Olympus video colonoscope. You'll hear diverticulosis, snare polypectomy, and maybe diverticulitis if it's infected. Okay, let's do, got a couple more here. We'll go into the laparoscopic cholecystectomy. This can be elective. It could be laparoscopic if it is usually, or open if it's an emergent situation. You know, you're going to have severe right upper quadrant pain, nausea, vomiting, fever. It's your gallbladder, and they're going to put you out for this. You're going to be in a supine position, and the incision is going to depend on whether it's an open or a laparoscopic procedure. These are some of the terms that you're going to hear over and over and over again, and these are the terms that you'll hear. Cystic duct, triangle of Callot, the cystic artery, the common bile duct, the hepatic fossa, fundus of the gallbladder. You know, you'll hear these over and over and over. There may be an intraoperative cholangiogram. Again, this is not the best picture, but you get it. Get a picture. Look it up. You know, this is a habit. You know, just get in this habit, this researching habit of visualization. It'll help you. This is something that you will hear, these phrases you will hear over and over and over again. A couple of things to note. Again, the millimeters of mercury, written as mmHg. And again, we do not hyphenate between metric, so 5 millimeters port would not have hyphens. But you will hear these phrases over and over again. The skin was closed with a running monocryle. Steri strips, make an expander for that. Common tools, Verus needle, cannula, hemoclip. You'll hear, you know, the cystic artery was then encountered and 2 clips were placed proximally and 1 distally. It was then divided. You'll hear that over and over again. A 5 millimeter port was placed under direct visualization. You will hear this over and over. Let's look at one more. And this is the appendectomy. It's usually emergent, and you know that is just you have nausea, vomiting, right lower quadrant pain over McBurney point. That's an eponym. So if it's McBurney's with no noun, it's apostrophe S. If the point comes after, there's no apostrophe S. Fever, elevated white count, right lower quadrant, and again that's going to be general anesthesia. And you're going to hear, it's going to be different types of incisions depending. Surgeons have certain incisions they like to make for different reasons. And you'll hear the mesoappendix, appendix, cecum, and peritoneal cavity. you're going to hear the abdomen or whatever surgical area was prepped and draped in sterile fashion very often. The peritoneal cavity was entered carefully. The appendix was brought out via endocatch bag. You'll hear trocars, scope, GIA stapler. All these things you're going to hear over and over again. These are all going to be for this appendectomy, you're going to hear this every single, just over and over. These are going to be consistent terms that you're going to hear over and over again. So while they may be scary to begin with, once you become familiar with these, you're going to hear these over and over again. I do want to talk a bit about MT911. It is a searchable site. It does not use our account specifics. It will not be verbatim. It may be a good source to look for the same anatomical terms. Again, we only have so many body parts. So certain surgeries will only contain certain body parts. So if you put the name of the surgery in the search box, and then you need to go down below the ones that have the little add boxes and then check it out. And then you can do a Control F for Frank, Control FF. Sometimes you have to hit it twice. And then put in, if you were looking for a specific suture, put in suture and see what pops up. It may bring up the suture you're looking for. If you know part of the word, put in that part of the word in that search box. If you know it, incision, if you're looking for an incision, put that in there and look. Again, a lot of these procedures use the same types of tools, incisions, and again, all of the same, pretty much the same body parts. So here is a couple of really good information websites for some good information. I'm just going to go through just quickly because I have a lot to list here. But I do want to remind you that your course has a great list of surgical positions, sutures, etc. So make note of those. On the websites, these are some websites from some of my co-instructors. I told them I was doing a webinar on surgery, and they offered to give me some of the websites that they use. And these are really good websites. Again, use your websites carefully, but and verify your information if possible with Stedman's or another resource. But these are very interesting websites, and this will be on the forum, and you can copy and paste them from there. And it's just a great amount of information here. That surgery encyclopedia is fantastic. That Harvard is, and the Mayo. Actually, all of them are really good on this site. These two are very good also, and they have really great pictures that you can look at and get an idea of what tool is what, and get a better idea of why, they use certain tools for what reason. So make sure that you look at that, check that out. This is the surgical, this has just a few surgeries on there. If you click on that, they do have surgeries, and there are other ones too. If you'll just Google like laparoscopic appendectomy surgeries online, you can, they will, and you put video, they'll have those on there. If you can stomach it, but be ready. I do want to mention again, some people don't know this, but you can use Control F to search for words or parts of words on any document, PDF, word list, your account specifics, internet, MT911, etc. For some reason, this is a picture that I pulled up, and the control is spelled incorrectly. They put CNTL, and it should be CTRL. But anyway, just hit the control and the F once to pull up the box. It may take you twice. Hit it at the same time. But if, say, for example, you're on your account specifics and you hit the Control F or hit it twice, it'll pull up that search box at the top. And then you can put in, say you're looking for information about headings, type in head, and it will bring up every instance of heading or head in that report. And this is, you can use it for, you know, just about every, like, Word document, a word list you have, you know, a Google, anything that you pull up, you can use this on just about. Remember to use all websites mentioned carefully. Again, confirm all spelling, if possible, with course material first, following the hierarchy in the order listed below. Account specifics first always. CanScribe, MTHCS course material, book of style, school and issued Stedman's resources, internet resources to ensure integrity and authority of specific sites for sure. So, in closing, I just really want to encourage all of you to embrace surgical reports. I love them. I think they're very interesting. And if you can stomach watching procedures online, it really will help you immensely. Check out that website that I gave you earlier. You know, it's not going to show you the hardcore stuff, but I mean, it's interesting. It'll show you the body parts the dictator is talking about. It'll show you the tools. It will help you make sense of just what the dictator is talking about. It really will help you for the future. When you transcribe the next report, you'll say, oh, I know what a retractor is. Oh, I know what that is. So it really will help you. Just Google a procedure you're interested in, but be ready. It's not for the faint of heart, I will warn you. But don't be afraid of them. Use all of your resources. Remember to find good illustrations to visualize. I can't stress that enough. Do look up these terms that you're unable to find when you get reports back after submitting them. Take that time. It's about effort. Learn about them. Add these terms to your word expanders. Add them to your word list. Most importantly, learn your anatomy. I just want to thank everybody for attending today's webinar, and I appreciate you all coming. And, well, thank you, and I'm so sorry that there have been some issues with the being able to hear, but it will be up on the forum for everybody to hear, and I hope you take advantage of the websites, and I'm just so glad that everybody came, and I appreciate it. Oh, you're welcome. Thank you. Thanks, Amanda. Thank you, everybody. Thank you, guys. Thanks, Ann. Thanks, Micah. Thanks, Lisa. Thanks, Christine. Thanks, Wendy.